It takes a long time to develop the technical physical ability for brain surgery. I do 300 brain surgeries a year. I don't believe in the continuous stable self in any way, shape, or form. You cannot tell just by looking at the surface of the brain one person from another. It turns out that CTE is not unique to American football. Dualism is built into our language. Boxers will develop movement trouble, shaking, almost Parkinson.
Today I'm speaking with Theodore Schwartz, one of America's most distinguished neurosurgeons. A graduate of Harvard, he's published over 500 scientific papers and has developed minimally invasive brain surgical techniques. Theodore recently wrote a book, Grey Matters, a biography of brain surgery, which gives profound insights into the complexities of the human brain. Enjoy my conversation with Theodore. We might just start off with a little bit of the history here, because I know you went into that in your book. So will you just tell me a little bit about Harvey Cushing and why he was so instrumental in the development of brain surgery and, I suppose, forwarding it as a discipline?
Yeah, it's rare that there's a field of study where there's literally one human being who, before that person was alive, the field essentially didn't exist. And one person was completely instrumental in creating the discipline and was essentially the forefather of every neurosurgeon to come. And that was this guy, Harvey Cushing. And he was born in the late 1800s and trained, as a general surgeon, because when he started his career, there was no such thing as a neurosurgeon. There were just general surgeons. Most surgeons were involved in battlefield injuries and would do everything. And they would dabble in brain surgery, but it was felt much too risky at the time to open up someone's skull. Most people died, every time the skull was opened. And when he started his career in 1905, he wrote a paper about the birth of brain surgery. The mortality of doing brain surgery was 50%. For half of every patient that he operated on would die either during the operation or soon after the operation from bleeding or infection, something horrible happening. And by the end of his career, the mortality of neurosurgery was only 8%. So it went from something that very few people did, because most people wouldn't want to take on that responsibility of basically killing half the people they took care of, to a field where, it was possible to leave people better off than when you found them. And that was really he was a very disciplined surgeon. He benefited from the fact that antisepsis had been created, that we were able to anesthetize patients and put them under, like all of those developments helped neurosurgery, because you needed a patient who was anesthetized, wasn't moving, couldn't feel anything. You needed to make sure that patients didn't get infections or meningitis. And so he really invented the field, developed the field, sort of codified all the different types of operations we did. And every neurosurgeon alive today owes an enormous debt of gratitude to Harvey Cushing.
Yeah, that's fascinating. I actually found that part of the book extremely interesting. Could you just talk about how did he actually accumulate knowledge? How did he develop the discipline? I remember you mentioned international trips in the book, so he went to Europe to study. So was it more that he invested time in researching, or was it technological advancements? Or could you talk a bit about what he actually did specifically?
Yeah, a lot of his trips were disappointing. He went abroad and he visited certain neurosurgeons, and he found that they really weren't as advanced as he hoped they would be. We did some physiology work in England with a guy named Sherrington, who was a physiologist who taught a lot about the physiology of the brain. But he really wasn't that impressed with the state of neurosurgery around the world. He kind of got what he could and then came back, and then, it was really up to him to perfect, develop, and move everything forward.
Okay, interesting. And I'm just curious about, so obviously neurosurgery or brain surgery, it's probably difficult to actually document those things, techniques in a textbook. So how do brain surgeons actually preserve knowledge across generations, and how do they transfer tacit knowledge? Because obviously it's the type of thing you can only learn when you're actually in there experiencing it. So how is it standardized and transferred across different generations?
It's a great reflection of how knowledge is transferred today, in that originally it was really a master-apprentice relationship. There was sort of the master surgeon, and people would travel from all around the world to apprentice with that surgeon. And we do residencies where the same thing is done. Most neurosurgery is transmitted from one neurosurgeon to another in the operating room where someone is teaching, there's someone learning, and someone training. It's really master apprentice. Now, there are textbooks of neurosurgery that are written, and I grew up reading these textbooks, and it tries to give you a sense of the anatomy. You try to get a sense of the physiology and the moves you're going to make. But until you're in there actually doing it, it's very, very difficult. So as you can imagine, probably 15, 20 years ago, we all developed videos, right? So everyone would start, first we were taking pictures during our surgeries, and then we started videoing during our surgeries. And now you can go on websites and you can actually watch videos of surgeries. I just documented, I uploaded 200 of my surgeries where there's videos.
Wow.
And then I would actually do a telestration where I was narrating the video and I would actually point to things on the screen, show people what was going on. So, information has been transmitted in various ways. Now we have these there's 3D, almost holographic illustrations of what the brain will look like. We'll take you through the steps of neurosurgery. So the techniques of transmitting information are getting better. You can wear virtual reality goggles now, which obviously didn't exist, decades ago, where you can watch what the approach would be. You can see the surgery and the anatomy that you're going to have to deal with. Because one of the things we face as neurosurgeons is you look at a scan, an MRI, a brain scan of some kind, and you have to imagine what it's going to look like when you get in there. And so you have to really have this 3D imagination that can take a two-dimensional image and turn it into 3 dimensions. Unless you've been in there and done it time and time and time again, it's very hard to do that, which is why there's a remarkable learning curve in neurosurgery from beginning to expert.
So obviously there's standardized anatomical models of brains, but on a person-to-person basis, how does the brain differ in subtle ways, maybe abnormalities aside? Like, is there subtle differences? Because obviously we all have subtle physical differences, and I presume you see that in brains as well.
Not really. When you look down at a human brain, they all look identical, right? Unless there's an abnormality, like you mentioned. If there's a tumor somewhere, an aneurysm, that looks different. But you cannot tell just by looking at the surface of the brain, one person from another. It's like saying underneath the hood, we're all the same, and we really are, regardless of the color of our skin, regardless of our intelligence, regardless of our education, our upbringing, or our religion. Our brains all look identical. Now, you can map the brain and find some variations. So if you asked me, well, where's the part of my brain that's important for language processing? That can differ from person to person. I know it's going to be roughly in a particular region, but I can't tell you exactly where it's going to be unless I map it out. So there is some variability in the function of the brain, but you can't see it by looking at the brain. It's it's a wiring difference, if you will.
Wow. And the way machine learning studies can predict or estimate brain age or biological brain age from MRI scans, that doesn't actually reflect anything that you'd see in a material sense, does it? Like, there's obviously very subtle things they're looking at there.
What they're looking at is brain atrophy, because over time, your brain will subtly atrophy. So it's almost like saying, if I looked at your bicep and I looked at someone else's bicep, could I tell the difference between the two of you? And the answer is probably not. But, as you get older, your muscles will atrophy and your skin will become a little looser. So I can say, well, that bicep looks a little older than this bicep, but it basically looks like a bicep. So, I can't tell one person from another just by looking at their bicep.
Okay, fascinating. So I'm curious about the training process, because obviously, like you said, until you're actually in there performing surgery, it's probably difficult to replicate the pressure of that situation. So could you foresee a setting in the future where maybe AI models through virtual reality, like you said, get so good to the point where you can actually replicate something like the pressure of an operation, or do you just have to be in there?
Well, if you're saying, can I imagine it? The answer is, of course, you can imagine anything.
Yeah.
I can absolutely imagine some sort of immersive virtual reality that looks so real that you feel the pressure. But you'll always know that nobody's life is on the line when you're operating a computer versus your own life on the line. So I'm sure when you're flying a plane in a simulator and the plane goes down, your heart rate is not at the same rate as if you were in that plane and the plane were going down. I'm sure there would be a physiologic difference. And that's something that's very hard to overcome, because when you start to appreciate and think about the gravity of what you're doing when there are problems, your heart rate does go up. Your heart rate goes up, you get more tense. And when that happens, your hands can start to shake. You can have a tremor. And all of those things will affect your ability to operate effectively. And it's very hard to mimic that in a scenario other than real life.
Okay.
The other thing that's very difficult, of course, even if things look similar, it's very hard to get that tactile feedback for the resistance of moving things aside. What does it feel like to dissect an artery off a tumor? Because that tumor could be firm, it could be soft, it could be any grade of firm and soft. The tumor could be the blood vessel, could be thin, it could be large, and there's a million different variations, right? So until you've been in those different variations and felt what that's like, it's very difficult to understand and mimic it and model it because it's just so variable.
So I remember you mentioned in the book that brain surgery is almost like a blue collar profession in the sense that it is very physical. So I'm interested in like the role of physical dexterity or perhaps psychomotor ability, because I imagine not everyone would have that level of dexterity in their hands. I certainly wouldn't. So is that a very important factor, and does that even rank above things like cognitive ability?
In the long run, judgment is more important. It takes a long time to develop the technical physical ability for brain surgery. That's why our training is 7 years long, because it takes a long time to learn what you have to do. But on the other hand, if you think about it, to a toddler, driving a car is a very difficult thing to imagine doing, right? You have to control the foot pedals with the feet. You have to turn. You have to be very accurate with it. And we all manage to learn how to do it. On the other hand, there's some drivers who can drive at 250 miles an hour. And there are others who have trouble driving, at 100 miles an hour or 50 miles an hour. And so there's a gradation of ability. But most of us can drive from point A to point B. And so most reasonably coordinated people, you can train to be a neurosurgeon and do a reasonably good job in many operations. But you can't train everyone to be a virtuoso, and you can't train everyone to do the most difficult operations, because not every brain surgery operation is of equal difficulty. Some of them are much easier than others. And the majority of them, I would say, are, sort of middle of the road in terms of their difficulty. And so almost any coordinated person, if they spend the time, the energy, the effort, and the practice, can learn how to do the majority of brain surgery operations. But there are always going to be cases that are extremely technically difficult, where the difference between a good neurosurgeon and a great neurosurgeon will become very apparent.
And do you think, is the barrier there perhaps confidence? Is it like maybe an ability to overcome the fear in an operation, or what do you think stops some people from pushing maybe to, like you said, to be a great neurosurgeon?
So it's like sports, right? It's a combination of physical ability and then mental fortitude, right? It's always a combination of both. You can have two athletes who are equally good technically and athleticism, but one of them is going to have a desire to win, or is going to make a decision under pressure better than another one because of something mentally that they're able to do. And that has to do with confidence and making decisions under pressure. On the other hand, there are going to be some athletes who are just physically more talented than other athletes, who may rise to the occasion because they're a physical ability. But in the end, if you think about it, I don't know. Actually, there was a football game in Ireland recently, right? So you watched the Little American.
Yeah. I've seen a bit of it over the years. Yeah.
Well, you think about, let's talk about quarterbacks. I love football. So you've got a quarterback like Lamar Jackson, who is a physical specimen, unlike very few other athletes. He's the quarterback for the Baltimore Ravens. He's an unbelievable athlete, right? But he's never won a Super Bowl. And then you take a Tom Brady, who his athleticism is just okay, but he clearly has an ability, a judgment under pressure, something in his mind that makes him rise to the occasion in those moments and make the right decision, with that he has 7 Super Bowl rings. But he's nowhere near as good an athlete as Lamar Jackson is physically, but he has something mental that he's able to do. It's also the team around you, of course, that makes a difference. But I'm sure you can make a rugby or a soccer analogy that's very similar, and will speak to your audience better than my American football.
Yeah. So it's almost like an intangible factor, like an X factor that just gives some people maybe the ability to go the extra mile. And you do often see that with athletes that, like, as you said, they might not be the most athletic, but they do have that something extra that allows them to be special. So that is fascinating. Just while we're on the topic of American football, so obviously it's not a big thing in Europe. So for listeners who haven't heard of it, could you describe a little bit about what CTE is, and I guess pathologically, and why it was such a big deal in terms of the NFL?
Well, it turns out that CTE is not unique to American football. And if you study enough rugby players, you will find CTE in your rugby players. But it's a disease called chronic traumatic encephalopathy. And it really was first described in boxers who get punch drunk when they get hit in the head enough times. And if you sustain repetitive head injury over a long period of time caused by anything, whether it's American football, rugby, whether you're in the military and it's blasts, or you're flying, jets and your head's getting whipped back and forth, we found now that CTE could be caused by a number of different things, even potentially heading soccer balls repeatedly, that over a career, and it has to happen over decades, you start to develop deposits of protein in the brain that will affect your cognitive abilities, and you become depressed and emotionally labile. For boxing, a lot of these boxers will develop movement trouble, shaking, almost Parkinsonian-like symptoms. There's a lot of different manifestations of chronic traumatic encephalopathy, but it's been very clear that this disease exists, it's real, and it's not just in American football, but it's in any activity that causes repetitive head trauma.
Wow, yeah.
And you don't have to have a concussion. The other important thing, Donald, is you don't have to have a concussion. They can all be sub-concussive head impacts.
Yeah, two things popped to my mind there straight away, so I'm just going to get your thoughts on them. So first of all, are you saying that what people such as Muhammad Ali, which is a very famous example of it, get or develop from boxing is very similar pathologically to what some American football players have gotten in the past? And also, why is there an individual variation here in terms of some people suffer and some people do not? Like, is it maybe thickness of the skull or other factors, or maybe it's just luck?
So it's definitely not luck, because there's no such thing. It's probably genetics, right? There's some people are genetically different. You could ask the same question. If you take 100 people and you make them smoke 2 packs of cigarettes a day, how come they don't all get lung cancer? And the answer is because some people are more predisposed or susceptible because of the way their bodies are built. Not every disease manifests itself 100% in people who expose themselves to the risk factors for that disease. And the same is true of head trauma. So the problem is we have no way of testing it when you're alive to know if you have CTE or not. And we have no way of telling who has a predisposition to contracting CTE and who doesn't.
Yeah, that's fascinating. Because obviously it's only something that becomes apparent after death, like you said. Am I right in saying that? Like, you can't actually tell.
We just don't have a good enough test. It doesn't show up on an MRI scan, but we will have a test at some point. We just haven't developed that test yet. Science hasn't advanced to the point where we can detect the early onset and early stages of CTE.
So the public understanding, well, my understanding at least, of a concussion is that the brain moves slightly in the skull. Is that too simplistic? Is there more things going on? Because I think that's what most people think if they consider a concussion.
Yeah, so the brain always moves in the skull, right? Because the brain is like an egg yolk. If you imagine you take an egg and you shake it, like if you move a shake around, the yolk is going to move a little bit with respect to the white, right? Because it's a different density than the white. The brain is floating in water. And so anytime you move your head, your brain is moving a little bit. If you move it enough, first of all, it can bang up against the skull if you have an acceleration, deceleration injury, and that can bruise the surface of the brain. But also, the brain has, millions and millions of these fibers, very, very thin fibers called white matter. Okay. And if the brain twists or shakes a little bit, it's almost like whipping spaghetti, soft spaghetti above your head. What happens is those fibers can shear a little bit, and it's called diffuse axonal injury, because the axons of the neurons are very long, thin fibers, and they will break and become damaged with any kind of rotation or acceleration, deceleration. That's really so. It's the how the forces are acting on the brain. The brain doesn't have to impact the skull only; it can also be just a fast twisting motion.
I guess considering what many sports can do to the brain in terms of decline, and even soccer, like you said, which many people would think is not obviously a violent sport, it's not necessarily an aggressive sport, but just the impact from actually heading the ball. What implications does that have for youth sports? Because I know rugby in my country has definitely tightened up maybe youth contact and stuff over the years. So is there implications we should consider for youth sport?
Yeah, absolutely. And, one of the things we've learned about American football and CTE, because it's the duration of time over which you have these small injuries, little kids should not be hitting, right? They should be playing flag football and doing that for as long as possible. You should delay the hitting as long as possible. And the Canadians have done that in hockey. There's some places where they don't start, checking in hockey until kids get to be at least in 7th grade, 8th grade. You don't start it in 2nd grade, 3rd grade, because it's cumulative impact, and the longer you go, it's possible you could end your career in high school, but you've been hitting your head for 8 years, and that can have a negative effect. So the later you start is better. And obviously, if you go on and have a career that takes you through university and a professional career, it's going to be a long career and you're going to be at risk. What we want to avoid is having a kid who just plays in high school and stops after high school. We don't want that child to be put at risk. And that means they have to start a little bit later. They're hitting so that they're only really at risk for about, 4 years.
Okay, interesting. So I guess maybe skill development should be prioritized before that, and then the physicality can come after. Would that be a fair way to put it? Yeah.
Absolutely.
And so I think I read in your book that girls are more susceptible to concussion than boys, and also obviously teenagers are more susceptible than adults. So could you speak a little bit about why that is?
Yeah. I have no idea why girls might be more susceptible, but if you look at the numbers of concussions per contact, per gender, it seems that it's a little more common in women than in men, and girls than in boys. I don't have a good physiologic explanation with that. But what I can say about on teenagers is there's the thing that most parents worry about the most with their child playing a contact sport is even more so than concussion is this thing called second impact syndrome. So there's a phenomena, and this happens every couple years, a couple times every year, a few times a year, a child playing football, either, it could be a teenager or even younger, will literally come off the field and collapse and die from a head trauma. And it was thought that they have a second concussion immediately after a first concussion. It's now thought that it doesn't have to be a second contact. It can just be a single big hit to the brain. But the younger you are, the more brain cells you have, the bigger your brain is with respect to your skull. And also there's a difference in the way you regulate the blood flow to your brain. And so this phenomena, second impact syndrome, occurs when a teenager has a big impact to the head, their brain swells, and the blood vessels bringing blood to the brain dilate and bring in even more blood flow. So it swells even more. And when the brain swells, it has nowhere to go because it's encased in the skull. And that increase in swelling leads to an increase in pressure. And if there's enough pressure that builds up, then no blood can get into the brain anymore, and the brain dies and swells even more. And you can, an individual can die or suffer a very big stroke, which is death of the brain cells or parts of the brain. So it can be extremely dangerous. It is rare, though. Even in American football, it's really just 3 or 4 kids every year of the millions of kids who play football.
Wow, yeah, but it's definitely something that people should be aware of. Can I ask you, has network thinking changed brain surgery or influenced maybe planning for operations? So not just thinking in terms of anatomical regions, but entire networks and how they connect together.
Yeah, we talk now about the brain connectome. And what that means is we used to just think about the areas, the brain has gray matter on the surface, which are the cells of the neuron. And then the white matter are those axons that I talked about that really are the connections. And we used to think about, well, we don't want to disrupt the nerve cells, will cause a problem. But now we've realized that the connections are just as important as the nerve cells, and that you have to make sure you know the pathways by which all the neurons communicate with each other. Because if you interrupt the pathways, the connections, it's just as bad as damaging the brain cells themselves. And so every part of the brain is connected to almost every other part of the brain. It's a very, very complicated network, but some pathways are more important than others. And it's very important for us to take that into account when we're doing brain surgery. And so often we'll do MRI scans on our patients beforehand, and we can do what's called white matter mapping, where we can create maps of these pathways through the brain so that we can plan our surgeries to avoid damaging some of those pathways.
Wow, fascinating. And at times, is there a tension between preserving neurological function and treating an underlying condition? And is there areas where this balance is maybe particularly tricky or difficult?
I mean, that's a very common balance. So, I often, people ask me another question that's related, which has to do with, why would you do brain surgery with someone awake, right? So imagine, we can do brain surgery. We often do. Back in the old days, they used to do it more commonly awake when anesthesia wasn't that safe. But you can anesthetize the skin and the covering of the brain, and then you can expose the brain and have someone literally awake on the operating room table talk to you. And we do this once or twice a month. We'll do this because sometimes you can have a tumor that's right next to a part of the brain that's very important for producing speech or language. And as I mentioned before, where I said not all brains look the same, the location of those language areas is different in everybody. So you have to map it out. So the way we map out language, neurosurgeon, we expose that part of the brain. We have the individual talking, naming, reading, doing various language tasks, and we're stimulating different parts of the brain with an electrode. And when we come apart a part of the brain that's important for speech, the patient on the table will have trouble speaking. Okay. And so that's how we map out language. So very often you'll have a tumor right next to a part of the brain that's important for speech. And you have to decide, can I take this whole tumor out, or do I risk damaging that person's ability to speak? And if it's very, very close, then often we're conservative with our surgery. And sometimes I'll be shaving away the tumor while talking to a patient, because I want to know the moment they're starting to have trouble with their speech. So I want to keep them talking. We'll have a conversation in the operating room. Tell me about your week. What did you, what's your favorite movie? What's your favorite book? Tell me about the plot of the movie, to get them talking while I'm shaving away their tumor, because God forbid I get too close. They have trouble speaking. I know I need to stop my surgery at that point. So often there's a sort of a Sophie's choice risk benefit that we do when we're taking out a tumor near a part of the brain that's extremely functional and important. And sometimes we just can't take the tumor out, because sometimes the tumors will actually infiltrate into those parts of the brain and they can't be removed without causing a significant neurologic deficit afterwards.
Well, yeah, I think that really gives people a sense of the complexity of the profession and the things that you have to balance. Could I also ask, is there, obviously we've made great progress in understanding the brain, but is there still a great unknown or something we don't know? Is there a frontier that brain surgeons maybe still don't know and are reaching towards? Because I think maybe a neuroscientist would probably say something like, we don't know exactly how memories are stored. But from a more anatomical point of view, is there something we don't know?
There's a lot we don't know, and it's very important to be humble in this profession. Something very basic, right? So I do 300 brain surgeries a year. There's an infection rate in brain surgery that's about 3%, 2 to 3%, right? So that means that, 6 to 10 patients every year are going to get an infection. We don't know how to prevent an infection in every operation. That should be simple. We give you antibiotics, we put betadine on your head to sterilize the skin. And that's not even getting into the brain. That's just doing surgery. We can't even open and close the head without preventing an infection 100% of the time, because we don't exactly know why everybody gets an infection. Because if we knew that, we could prevent it 100% of the time, but we can't. And then in terms of brain function, we can only map certain things. We can't really map everything. We don't have an ability to map everything. So we can map motor. I can tell you where the part of the brain is that moves your arm, your leg, your face. I can tell you the sensation parts of the brain. I can tell you roughly vision, but the problem is there's an enormous amount of your brain that processes vision, and we can't really map all the little other parts that process vision. And the same thing for doing sort of complex analytic analysis. Some of those things we really have trouble mapping because our techniques are very primitive. And the better we get at mapping the brain, the more effective we'll become at removing things from the brain. Because every once in a while we'll do a surgery and one of our patients will wake up and won't have exactly the same functioning they did before, even though we did everything we possibly could to prevent it. And then the corollary also happens. Sometimes we take out a tumor and we're worried about there being a postoperative problem, and the patient wakes up perfect. And we're amazed and surprised, given how aggressive we were with the surgery in their brain, that they didn't sustain a more severe deficit, but obviously some other part of their brain took up the slack, or the tumor maybe damaged that part of the brain more than we thought. So we really don't have a great real-time understanding of the functional connectivity of the brain, what every part of the brain is doing and how it's talking to every other part of the brain. We have a general sense, but not detailed.
That's really interesting. I guess in a lot of sciences, people say that the reason that progress gets harder over time is because a lot of the low-hanging fruit has been picked. So is that similar in brain surgery, or is it more to do with technological progress? Like, what would enable brain surgeons to keep advancing?
Yeah, the low-hanging fruit are picked, but we're constantly developing new techniques that create new low-hanging fruit. So if all you have are your eyes looking at the brain, then you can only learn so much. And once you have CAT scans, you can learn more. When you have MRI scans, you can learn more. And you have PET scans, you can learn more. And so with every new technique we develop, then suddenly there's all this new long-hanging fruit, because suddenly we could see things that we never saw before. So I don't think that it's harder to make inventions as long as we keep developing new techniques to study the brain and study its connectivity. Then there'll constantly be new low-hanging fruit. And there are new things, questions that we can answer with our new techniques as we technologically progress, as you said.
I just want to ask you as well about, so you actually painted very vivid portraits of the types of personalities that you see having a career in brain surgery. And I just remember, actually, as we're talking, a book that I read a few years ago, I think was called When the Air Hits Your Brain. And I think in that book, they kind of portrayed brain surgeons maybe as jocks, or kind of high achievers. So where does your assessment lie? Like, what types of people maybe go into the profession, and what common traits do you see in people who really excel or become great surgeons, like you mentioned earlier?
So yeah, I'm going to create the analogy of like the high school lunchroom. Different people sit at different tables. So you have the nerds at one table, you have the musicians at one table, you have the jocks at one table. And there's a lot of things that push people into neurosurgery. And there's definitely some people who are athletes who like the physical challenge. They're type A personalities. They don't run away from challenges and conflicts. But there's also nerdy brain surgeons who are interested in the science and how the brain works. And then there are also, musicians who practice their instrument. It's a technical feat, something that you are used to sitting down and becoming better and better at, using your hands and your fingers, and they can be very good neurosurgeons. There's some neurosurgeons who go into it because they were touched by neurosurgery. So they have a family member who died of an aneurysm or a brain tumor, or maybe they have a family member, a parent who went into neurosurgery. And so they want to follow in their footsteps because they admire that person. Or you have minorities and women who sometimes are facing challenges and feel like they need to prove themselves. And because neurosurgery is thought of as being a very hard thing to do, which requires a lot of sacrifice and difficulty, and has previously been dominated by white men, it becomes a profession that some may be motivated to go into because they feel like they're representing a group, and they want to show their ability to achieve as a representative of that potentially previously underrepresented group in neurosurgery.
So I remember seeing in your book that you said that we lose 50,000 neurons a day just from normal aging. And I'm just wondering, what does that say about maybe the idea of a continuous, stable self?
Well, I don't believe in the self. I don't believe in the continuous, stable self in any way, shape, or form. So I think it says what you're imagining. It says we all know that we change over time, right? Who we are today is different than who we are 10 years ago and 20 years ago, and that process is gradual based on every new experience you have. Your self evolves. And your self diminishes as we get older. You forget the names of things. If you get out, God forbid, you get dementia. You could no longer recognize your family members, or the people closest to you. And if you can no longer remember, your favorite activity or your closest relative or your wife, are you the same person that you were before? And the answer is no, you're not. You're somebody different. And once you see what we can do, what can be done with neurosurgery, for example, you can put electrodes in someone's brain and you can change their mood dramatically. We can make depressed people happy. We can make people who have obsessive compulsive disorder lose those disorder by stimulating the brain in a certain way. There's a very famous case of someone who had an electrode put in their brain for obsessive compulsive disorder, and they turned it on, and the patient started enjoying the music of Johnny Cash. And when the electrode was turned off, they didn't like that music anymore. So if you can alter your musical taste by merely stimulating an electrode in your brain, and you think of your personality as what kind of music you like, then dramatic parts of our personality can be altered very simply by altering the brain. Just like a frontal lobotomy is obviously altering one's brain, and it dramatically changes one's personality back in the day when we were doing frontal lobotomies. So the brain is who we are. The brain is a physical object, like a river, it changes moment to moment. And so the self and the personality also changes moment to moment. We are not stable.
So as you were saying that, something just popped into my head. Like, do you still see a continuation of dualistic thinking in people who are experts in this area? And if so,
What thinking? What kind of
dualistic thinking, so maybe non-materialist thinking. And do you think that, does that still persist even amongst brain surgeons? And if it does, why do you think people take that philosophical conclusion?
Well, dualism is built into our language, right? We are raised in a world, once you learn how to speak and talk, you learn dualist philosophy. It's the most natural philosophy because, for example, we have a word for mind, we have a word for brain, right? We have a word for soul, we have a word for brain. But if you're a materialist, you don't believe that there's a difference between those two things. They're identical. The mind and the brain are identical. So why do we have two different words? And if you have two different words, then it makes you think that they're two different things. And there's a long, rich tradition. Most of our religious traditions are based in dualism. There's also, if you think about our ethical legal system, is based in a sense of dualism, in a sense that, there's a self that makes a decision to control the body to do a certain behavior. And therefore, you are guilty of committing a crime because you have chosen to commit that crime and you need to be punished. Whereas if you're a materialist, you believe that the brain really chose to do that for you in a way. You may have a faulty brain, but, and the punishment for that would be very different than saying, well, you're just an unethical person or an immoral person who made that decision. So dualism is really built into the infrastructure of all of our institutions, our organized religions. And it's hard to break away from it. You really have to actively try to imagine a materialistic, a purely deterministic world, and it's challenging to do so because so quickly you fall back into dualism.
Do you think that's like entirely cultural influence, or do you think there's actually something evolutionary built in there? And as well, is there something in the brain that gives rise to like the perception of having a religious experience? Because obviously a lot of people deeply believe they have them. Like I personally believe in maybe a non-dualistic way of thinking, but some people certainly think they do believe in or see maybe spirits or religious figures. Do you think there's a reason for that?
I do. I think it's a long question, but for example, we know that, for example, Dostoevsky had a seizure disorder, and every time he had a seizure, he felt the presence of God and a close connection with God. But we know that feeling was elicited by an abnormal firing of neurons in his brain. It doesn't mean that God didn't put that abnormal firing in his brain, but it was clearly linked to brain processes that was a disease. On the other hand, I think as human beings, we have a desire to understand why things happen. We want to understand why good things happen, why bad things happen. We want to feel that there's justice in the world. And 2,000 years ago, 3,000 years ago, when religions arose and we didn't understand science and how the world really works, we had no understanding of physics. The best understanding for why the sun rises and why diseases start was there must be a reason, or you were being punished for this. Someone is turning the lights on every morning and turning the lights off at night. And so you create stories to explain the phenomena around you, so you have some understanding of the universe. And those stories are very powerful, and they've persisted into our culture today. But we now have alternative explanations for why diseases start and why bad things happen to good people and good things happen to bad people. And so, the language and the story of science hasn't fully, unless you're a student of those, unless you're able to shed the stories that you're raised with, and the dualism, and even the belief in God is built into our language. I mean, that's just how we talk. We have expressions that express religious ideas. So it's funny, when my kids were little, I used to, all the expressions in our language that use the word God, or why does this happen, I would always substitute nature.
Okay.
Nature did this. Like, why is this the case? Well, nature has created us this way, or nature works in mysterious ways. So you can consciously make those substitutions to make language less dualistic than it has to be. But I think our brains are wired to try to understand the world around us and try to create stories to make sense of the world around us. And that's just how we're built.
That's really fascinating. A really interesting way.
Evolution. Yeah. And it's evolutionarily advantageous to feel that way, because also it's important for us to feel like the self exists, like we have agency, because then we feel like we're important. And that allows us to try to, the idea of self-preservation, you have to have a self to have a desire for self-preservation. And so the feeling of a self is very important for evolution and adaptability and survival, because, we feel like we have a self, and we want to preserve that self.
Given that, do you think that the philosophical view of free will still has any meaning? Does it even have, can you even maybe boil it down to a sense of agency, or is there anything left of free will worth preserving?
Well, there is a big mystery, even if you're a true determinist, which is that consciousness is still a mystery. Why is it like something to be me? There's an experience that I'm having right now, on this podcast talking to you, and you're having your own experience, and science has no clue where that experience comes from, how to measure that experience, why you have an experience at all. That is an enormous mystery, even if you're a diehard determinist. It's very hard to explain that away and understand it. But, that doesn't mean that determinism is wrong. It just means it's incomplete.
Do you consider the brain a information processor like a computer, or do you think there's something else going on there? Do you think it's mainly we process information and we create a reality?
Yes, I do think it's an information processor, but it's a unique one. I think it's very different than a computer, because our brains evolved on a planet. First of all, our brains evolved attached to a body, right, which is really important. That physicality, and our brains evolved on a planet where we had to figure out how to find shelter and food, and how to reproduce, and how to interact with other human beings and create a culture. All of those problems we had to solve led to the way that our brains evolved, so that and how we imagine the outside world to be. And computers also are information processors, but they're processing completely different information than we are, and they evolved in a completely different way than we did. They evolved, in a box on someone's desk, getting power from an outlet, being fed, and they're designed to solve complex mathematical equations, whereas we were designed to solve physical equations. Like, the most important things that we got to figure out is how to find food and throw a rock to hit an antelope so we can eat, and how to reproduce and how to build a house. And there's all these physical problems, which is why, the other thing I like to talk about is, like, will an AI and a robot ever replace a neurosurgeon? And I always say no, because we've evolved to solve physical problems as human beings. And AIs and robots are not particularly good at solving physical problems. If you ever see the robot soccer game where they put the robots on the field, but football, they're horrible at it, right? They can't play because they're not physical beings. They're really good at playing chess because you can. That's a different type of skill set than solving a physical problem, because a chessboard has the same board every time, the same players that do the same thing every time. The rook is not going to suddenly jump over 50 pieces and choose to do something else, and the board's not going to change its size in the middle, which would mess a computer up. But a human being could adapt and figure that out, because then that becomes a physical problem that's changing. So we're both information processors, but we're designed dramatically differently because we're designed to solve different problems.
That's fascinating. When you put it like that, it really amazes me how much we've done and how far we've progressed, considering what we actually evolved for. Like it does amaze me what our brain can do. Like obviously we have the help of tools and technology, but at the same time, like the fact that we can utilize it to the degree we do is amazing. And so I'm going to ask you, maybe it's a philosophical question. I don't even know if it has a clear answer, but I was thinking about like how I'd word it. But if we could emulate a whole brain, so people have talked about whole brain emulation for years, like down to everything, like down to ion channels, glial cells, maybe real time states and perfect memory. If we could emulate that, like create a psychological twin, is that an equivalent? Is that the same person again, or once inputs diverge, is that somebody completely different, or was it even the same person to begin with? Yeah.
So if you could literally reproduce every molecule in your brain identically, right? Let's say that was possible, which it probably isn't, but let's say it were. The millisecond that reproduction of you came into being, you would be identical. But the next millisecond, you would diverge, because that other you would have different experiences. It would be physically in a different place. It would see different things. It would suddenly interact with the world in a different way. And it would diverge from you because it would become you on another pathway, right? So it would not be you. It would only be you for the millisecond where it's born. And then the next millisecond, it would be different.
Just kind of maybe on a related point. So in neuroscience and maybe in cognitive science in general, some people, I think, misinterpret what neuroplasticity is or how the brain can change. Maybe you think like the brain is almost like mush. It can be changed like maybe to a continuous degree. But from a brain surgeon's point of view, like how do you view plasticity, like neuroplasticity in the brain? Like how impressive is it? I guess you'd have to consider this from maybe a healing perspective after surgery.
Right. That's right. Right. So it's different than when a child developing a neuroplasticity when you're young. So there is the ability for the brain to adapt. One of the surgeries we do, here's a great example, is called a hemispherectomy, where if you have a child and half their brain is diseased and there's seizures coming from half the brain, the treatment is literally to go in and remove half their brain. Right. And if it's a child who's going to develop language on the left side of the brain, and you remove the left half of their brain, but you do it when they're young enough, they will develop language on the other side of the brain. And they'll use that other side of the brain. Normally, the left side of the brain controls the right side of the body, and the right side of the brain controls the left side of the body. If you remove it when they're young enough, that one side of the brain will now control both sides of the body.
Wow.
So there's a remarkable amount of plasticity and learning that can occur. Again, it's the younger you are, the more plasticity there is, and the older you are, the less there is. But there's obviously some genetic chemical switches that turn on and off. And once we figure out what those are, there's no reason we can't try to keep those on longer so that in adults, they can recover. There is neurogenesis in certain parts of the brain all the way through adulthood and the olfactory bulb, things like that. Memory obviously involves a lot of plasticity, because every time you make a new memory, you're obviously plastically changing your brain to encode that memory in your brain. And we know with intensive rehabilitation that someone who has lost some motor function can regain some part of that motor function, assuming enough of the neurons are intact, they can recruit other parts of the brain. So it's a window that closes, but it doesn't completely close. And the goal, and many people are working on it, is to keep that window of plasticity open as long as possible.
Wow. Imagine if you could use, like you said, neurogenesis to treat certain dementias and Alzheimer's. Like that would be an absolute game changer, but it's probably extremely complicated. Like how would you even think about doing that? I'm just thinking of this in this.
Yeah, I mean, Alzheimer's also is not just about neurogenesis, but it's this buildup of plaques. You'd have to get rid of all those proteins and plaques that are gumming up the works.
Like some drugs are doing now, but to a degree. There is drugs that
trying to do.
Yeah, trying to do. Are you impressed with brain-computer interfaces, and where do you think they're going? Like how much can we do with them?
Yeah. So I'm very impressed with them. I wrote a lot about brain-computer interfaces in the end of my book.
Yeah.
First of all, tracing the history. A lot of people don't know that the first brain-computer interface was created to restore vision in the blind, and it was in 1962. A neurosurgeon named Tracy Putnam put wires in the visual cortex and attached it to a handheld photoreceptor, so someone could just walk around with like a flashlight, a blind person, and they'd get little flashes of light in their brain. And over time, it's now most brain-computer interfaces are to try to take motion out of the brain. That we're really, really good at doing that. And you can do that either by putting electrodes on the surface of the brain, the small electrodes into the brain, because every time we move our hand in a particular way, or move our legs, or move our tongues and our mouths to say something, the neurons in the brain fire in exactly the same pattern to create that movement. And so you can take if you have someone imagining writing with their hand, so they're writing in script, or moving their hand, or talking, you can then take those movements out of their brains and translate them into actual words. So you could have a robot that's speaking, or words appearing on a page, or a robotic arm moving for someone who's paralyzed, or you can just control a cursor on a computer screen. So, someone who's paralyzed, the information for moving left, right, up, and down, and for typing on a keyboard, all that information could be taken out of the brain without just directly from the brain into a computer, that a paralyzed person can then control a computer, or control a robotic arm, or drive a car, or do anything that involves movement. What's much harder is putting information into the brain. We're not good at doing that, because then you have to find a way to fire a lot of neurons in a particular pattern. And we're not as good as doing that. It's much easier to record them, because to record neurons, you just have to put an electrode near a neuron, and when it fires, you'll record it. But to stimulate it in a pattern is much trickier, because you have to have a lot more electrodes, and you have to be able to fire one neuron at a time. And that's more challenging for us to do for millions and millions of neurons, which is what it would take to put information into the brain.
Thank you. That was absolutely fascinating. I really enjoyed that conversation, Ted. I really appreciate it. And as I said, I really enjoyed your book. Your book is fantastic. Grey Matters: A Biography of Brain Surgery. It's absolutely amazing. So thank you so much for your time.
Thank you, Donald. It was a pleasure being here. It really was.
Yeah.
Enjoy the conversation.